A bit of an introduction. I'm a doctoral candidate at the University of Chicago in the Department of Sociology. And I'm also affiliated with the Department of Medicine and Infectious Diseases. So today, I got a really good lead in here actually to discuss the networks of people who use opioids non-medically, but I'm focusing on a rural area, in my case, Southern Illinois. Okay, there we go. So just a few acknowledgments and disclosures before we get started. So first, this study is funded by the National Institute on Drug Abuse, which is under the NIH. I'm also receiving fellowship support from Duke, and special thanks to Dana and Jim over the past year. Actually, I left my fleece here, and Dana was kind enough to keep it, so I'm looking forward to picking that up. I have no conflicts of interest to report, so we can go ahead and jump in here. Okay, so this is just a little bit of a roadmap for the presentation. I'm gonna condense some of these things since I think we got some really good feedback and context in the last presentation. But first, I just want to set the stage a little bit, just talking about the rise of opioid misuse in the US. And then I'm going to transition to a talk to looking at the surge in opioids in rural America, again, focusing on this Southern Illinois case study. And then a lot of what I'm going to discuss today is really going to be centered around methods and just in terms of what we did in recruitment and some of the challenges that we had there. And this is going to focus on RDS, which we just talked about extensively. And then we're also going to talk a little bit about venue-based sampling, which some of you may be familiar with, most of you. And then we'll wrap up with a discussion of some of the challenges and some of the early descriptive findings. And then I'll end with a talk of some of the next steps and some of the different adjustments that we've been trying to make in the field. So again, I think we got a really, really good background and context in the last presentation, so I won't overstate any of these points. But suffice to say, opioid misuse is a big issue in the United States. The clinical term that we're using, particularly at the hospital when we're trying to operationalize this, is saying that it's a pattern of non-medical usage, typically involving some level of impairment or dysregulation. It's very, very much a clinical paradigm. And it affects roughly 2.5 million people in the United States. In 2017, the CDC is estimating that just a little under 50,000 people had opioid-related deaths, and most of these are associated with overdoses. And this is nearly 5 times the rate at the beginning of the 2000s. So in the course of 15 years, this is pretty dramatic and scary. Around 40% of the current opioid-related deaths involve a prescription opioid. So you're probably familiar with Vicodin and Oxycontin. But additionally, we're also observing different increases when it comes to illicit opioids, heroin, and also synthetic opioids like fentanyl. There's probably things you've seen in the news over the past few years about this. Fentanyl is 100 times more potent than morphine and 15 times more potent than heroin. So that gives you a little frame of reference there. And collectively, when you looked at the broader picture here, this really highlights an issue on the regulatory end in terms of how we manage the prescription or the overprescribing of opioids. And also it becomes a question of public health miscalculation in terms of what is an epidemic, when do we notice it, and what do we do to try to mitigate some of the effects of it. So turning to the rural dimension of this work, a lot of the spatial analysis that we're seeing currently over the past 5 years shows that there's a particular uptick in non-medical opioid use in America's rural areas. In general, we know a few things about these rural spaces. One is that there's generally increased mortality associated with these opioid painkillers. Again, we talked about Vicodin and Oxycontin. There's also higher rates of non-medical opioid use among adolescents, as we learned in the other presentation here. And then another interesting thing that started to emerge here is this issue with lacing. And just through the course of some of our work over the past couple of years, when we talk to people who are in this population, we're saying, have you ever used fentanyl before? And they'll say, I think I did, but I had no idea that it was in there. So a lot of times, the concoctions that are being created, they have added chemicals in them, a lot of times fentanyl, which again, will really knock your socks off, to put it mildly. So some other things getting at sort of the broader context, the macro level influences here. In rural areas, we know, and actually this is really throughout the Midwest, which is our focus, that there's very diminished employment and education landscapes. And a lot of this is just generally associated with the industrialization and disinvestment in these communities. And a lot of this is associated with the movement of, or the closure of manufacturing, coal mining, and agriculture industries in this area. And related to that, we know there's a higher prevalence of individuals with comorbidities. So when you think of depression, chronic diseases, chronic pain, which incidentally, this is resulting from these physically intensive jobs in manufacturing, et cetera. And then more broadly, there's these structural issues with just limited access to primary care. Then also looking at clinical treatment, inpatient, detox, et cetera, just having difficulties accessing this due to issues with health insurance and also just what's in the community, what's in the area. Do you have to travel an hour away to go see a primary care physician? There's also a really interesting component here that I'm sort of framing as a sociocultural gradient. And this is more aligned with some of the work that I've done in the past, which has been primarily qualitative in nature, where you find in these communities, people hold very hostile views towards this population, which may not be that surprising. And we actually did some qualitative work, which I'm gonna talk about a little bit here, where we're speaking with healthcare professionals, courts, faith-based organizations. And they have really antagonistic attitudes towards drug use, harm reduction, and treatment in general. So obviously this creates a hostile environment for people who are struggling with these conditions. So I'm not going to cover all this here, but just to give you a little bit of the landscape of Southern Illinois, which we refer to as the Delta region. Consistent with some of the other facts that I pointed out here, they've had a very dramatic rise in prescription opioid-related mortality, and also a focal point for us has been the increase in drug injection. So it's also very uniquely situated geographically because you have Missouri to the west, Indiana to the northeast, and then Kentucky to the southeast. So in terms of the flow of drugs into these areas and the different laws, when it comes to prescribing medications, it gets very complex in terms of what's allowed and what's not allowed and what can be regulated. And also, again, don't want to overstate this point, but there just has been this very deep and stark deindustrialization process and population decline dating back to the 1980s. So even though these are relatively small counties, when you look at some of the charts, you look at one county and say, okay, they lost 100 people, but that county had, 1,000 people in it or 2,000 people. So these are actually pretty substantial decreases. And then I'll just end on this point here, noting that compared to other areas in Illinois, Southern Illinois has very high rates of poverty, mental illness, and chronic disease. So this here is a picture I like. So this is Orient 1, which is a coal mine. I think started probably towards the end of the 1800s. This picture was taken in 1915 of a coal mine in Franklin County, Illinois, which is that southern region that I just talked about. I believe they closed somewhere in the mid-1950s, but this is actually one of the largest coal mines in the entire world, at least at the time. Okay, so now getting into our study. So this is a mixed method project that focuses on patterns and drivers of opioid use and drug injection in rural Southern Illinois, focusing on this 17 county area, the southernmost in Illinois. It's a collaboration between University of Chicago and Southern Illinois University. So we're actually a part of a cluster of 9 other high-risk sites. So you see a couple of them here, Kentucky, North Carolina. The partner there is actually UNC. I'm not sure if you know Bill Zuhl, you're probably familiar with him, and others are. But he's leading that project out there. And these are all just high-risk areas that are looking at the same things that we're looking at. In the case of our particular orientation, we're very much focused on building or understanding different intervention targets for prevention, harm reduction. People familiar with naloxone and Narcan? So basically, this is just an overdose reversal tool that people use that can be injected or taken nasally. And also just some of the broader treatment challenges that are associated with this population. So looking at some of the core components, the main sort of orienting factor here has been a broad survey that we do with people who are in the study. And this is people who use drugs. And as I try to operationalize this today, when I say people who use drugs, it's an easy acronym for me to work with. But really when I say this, I'm primarily referring to people who use opioids non-medically and people who inject. So we go after a lot of the usual suspects here, trying to understand which opioids are used and what's the frequency of that. What are some of the different socioeconomic factors that are associated with use? And again, getting at some of the different barriers and challenges that are associated with treatment and harm reduction. And then for the purpose of this presentation, there's a big focus on networks. And in particular, we're looking at social support, drug use, and sex partner networks. So I'm not going to get too much into this here because I have some tables that outline this, but just generally being concerned about social support network centrality, the network composition for these drug networks, and then also looking at the size of the networks, and all of this being associated to different levels of risk in these populations. So other things I'm briefly going to talk about here, I mentioned that we had a qualitative component, which is a pretty heavy sort of anchoring component to the work to contextualize what we're finding on the quantitative end, where we're doing these interviews with stakeholders and then also people who use drugs. And then we also had this partnership with Illinois Department of Public Health where we're doing some level of surveillance to try to understand at a more macro level what the trends are and where the pockets of particular elevated usage are. And we're also been collecting blood and biospecimens to do different levels of testing, primarily focused on HIV, Hep C, and STI. So just to give you a little bit of context for what we know right now, so there's certainly research focused on the networks of people who use drugs, but there's not a ton of research focused on people who use drugs who are in rural communities, which is the gap and part that we sought to try to fill here. One thing that we do know from prior research, and again, this was brought up in the prior, alluded to in the prior presentation, is that people who inject heroin tend to have higher rates of HIV and hepatitis C. And the important gradient there is looking at the group composition, because a lot of times we frame heroin in particular, but drug injection as like a group activity. So there's a group composition component here that we're trying to suss out through this work. And in particular, we're concerned about needle sharing. Are they clearing? Are they using clean needles when they're sharing? Are they sharing at all? They're using dirty needles. Who are they doing it with? And then also looking at sort of the scope and the breadth of their sex partner networks and what sort of measures they may be taking to reduce different risks that are associated with practices of having multiple partners. So briefly, a little bit of an overview for the criteria. For the Delta Rural Health Study, we started recruitment back in August, and we're expecting to wrap up in 2019. I know this probably appalls you, but we're only looking to enroll around 200 people. We'd like to get a lot more than that, but this is sort of within the confines of the grant. And really what I'm going to present here today is going to be largely descriptive, but so far we've enrolled around 165 people. Here's a criteria here. I won't really get into too much of this. I actually don't think we've recruited anybody who's been under 18 years old, but the main thing that we focused on here was just making sure that they used any opioid to get high by any route. So this could be injection, snorting, smoking, etc., or if they injected any drug at all in the past 30 days to get high. And we verify this via a urine tox test. Otherwise, just note that we obtained written consent and that this study was approved by the University of Chicago and also as well as Southern Illinois University there. So we got a good coverage of this already, so I don't really need to overemphasize anything here. But one of our primary mechanisms for recruitment was respondent-driven sampling. And this is really ideal, again, for working with vulnerable populations and hard to reach populations. I think this is doubly important when you're talking about rural areas, when you're having issues with density and the concentration of people. So similar to the other approach that was discussed here, we use a voucher-based system, which is maybe slightly different from using a coupon, but I think it's essentially the same thing. In our case, and actually across the other sites, I think all the sites were using up to 6 different vouchers. So when you're working with the egos after the interviews, you say, you know, here goes 6 referral forms. If you have people in your network who you think fit the criteria that we have for this, then let them know. And I'm actually going to show you a little cutout of what the voucher looks like. Another thing that was important, this was also brought up, was having this passage on the back of the voucher that basically just says anything you disclose, well, not everything, but most things pertaining at least to usage, they're covered by this federal certificate of confidentiality. And this is just another layer of trying to reassure people that we're not out to, you know, snitch on you and tell the cops that you're doing X, Y, and Z. So the funding mechanism that we employed here was actually pretty interesting. We started off offering people $10 for each referral. And then at some point we realized that like this really wasn't enough juice to get people interested in the work. So we bumped it up. Actually, there's an analysis in place right now to see if there's been a substantial uptick. I honestly don't think that there was, but I think 20 just generally sounds better than $10 for each referral that you have. So this is also in addition to the survey and the interview, which you could get $40 for each. So there's a substantial amount of money to be made from participating. Another thing I'll mention briefly here is that we had a community advisory board, which consisted of some of these local stakeholders that I referred to, and also residents, many of these people being people who are actively using. And the goal, or at least one of the goals of the community advisory board, was to help us generate ideas on how do we engage this population, and how do we go about most effectively sort of embedding ourselves in this space and developing the authenticity that we need to really be powerful players here. Given that we're coming from Chicago, we don't know much about these communities. Like, we had this natural barrier going into Southern Illinois. So this is the front of the voucher, basic contact information. We try not to say too much about what exactly we're doing for the risk of stigmatizing people and saying like this is about drug injection and who you have sex with. So we kept it pretty linear here. Much of this is just focused on the contact information. There's also an agent code word here. Each voucher has a code word that's associated back to a database that we have, so we can sort of track the linkages for these different recruits that we have. And in the back is a federal certificate of confidentiality that I spoke about a little bit earlier. So really, what really paid dividends for us was not the RDS, it was this venue-based sampling. And we tried to use them in tandem, but by and large, it sort of just took on a life of its own, where each month we would hold these events in Southern Illinois public venues, and we had our study staff available there to provide general information about the study and our aims and purposes. And typically, we were just going to local gas stations. Like, these struck us as the spaces where you're going to get the average person who's living in these communities. And it was an opportunity, one, for us to have these cookouts where there's hot dogs and burgers, drinks, etc. And it was an opportunity just more broadly for us to engage people on a one-to-one level and let them know what we were doing. So if you look at this as, in the framework of feasibility, and just like what the return on investment is, first, there's definitely an investment that you have to make in terms of your staffing. You have people who have to work in the morning, in the evening, sometimes on the weekend, which can be a little bit tricky. There's also a lot of coordination that goes into working with the business operators, which in our case was working with a lot of these local gas stations. And then there's a lot of recurring expenses that may or may not be difficult to report back to the NIH to say you're buying hot dog buns and things like this for this project. And in particular, when you can't really account for the turnout. So in our case, we're holding these events and there's no guarantee that the people are going to come. It could be a cold day, which happens a lot in that area. So you really don't know what to expect. But by and large, we're really satisfied with this approach. We haven't done a formal analysis to see like what was the uptick or change in the number of recruits that we had between just the traditional RDS and then focusing more on venue-based sampling. But we have a general sense that, one, people are appreciative of us of being in this space. They like the free food, like this is pretty much a universal thing. And then again, like it's just nice for us actually to be there, sort of come from the Ivy Tower at the University of Chicago and actually be down there and engage with people. And then I think, on a more practical level, this gave us a really nice opportunity to directly engage and identify people who would be eligible for the study. So in a lot of cases, but not all cases, I would say out of maybe the 15 or so events that we did, we would find people and say like, here's eligibility criteria. And they'd say, yeah, I think I'm eligible for this. Like, here's my number, follow with me in a couple of weeks. We did, and these were people who actually ended up being in the study. And then also as an opportunity for us to look at other attendees who weren't eligible, who might know a cousin, a friend, somebody at their church who could potentially be eligible for the study. So this is an event that we did back in November. This is Stacy, one of our staff members who's out there. Doesn't look like we had great turnout this day, but she's definitely got a smile on her face, which is good. So, I'm gonna, how are we doing on time? Okay. So I'm gonna speed through some of this because a lot of these things are just instrumentation and items that you're probably very familiar with. But the social network questionnaire was really focused on, again, the social support. Who do you rely on for support? Who do you trust in? Who may you go to for money? And then who do you use drugs with? Who do you have sex with? And then on the other side, which we thought was semi-novel, which hasn't quietly panned out yet, but we said, let's find a way to track the usage of these vouchers and try to identify different challenges that the seeds have in actually recruiting people into the study to give us a better idea of like, how are we operationalizing productivity? What does that mean? And what can we do to better encourage or sort of train our seeds to better recruit participants into the study? And I won't go through all this, but these are primary questions that you've probably seen before. The first focused on drug use. Who have you used with in the past 6 months? Which type of drug? And then give me the name. And I'm going to problematize this last row here because you're probably already like, this looks a little strange. The next questions here get a little more explicit, asking about specific sex acts in the past 6 months, with who, the names, and the last one here is on social support, and the same sort of format applies with that. So now I'm going to get into some of the brief descriptives, and really everything here is oriented around the methods and some of the descriptive findings that we've had so far. So first, I'll note that the population was around 40 years old. So this is substantially larger than what we saw in the last presentation. Primarily white, male, less educated, and most people were unemployed, unmarried. The other thing I'll notice here very briefly is we have this question about whether they ever use opioids non-medically or injected the drug. And there could be overlap between these categories. I didn't create a variable for that, but just so you know, we definitely had most people who use opioids, but a lot of people inject it. So just sort of keep that in mind when you think about their actual frequency of use and the actual types of usages. So this table here gets into the RDS approach. This is strictly looking at the productivity of the seeds. So initially we had 42 seeds, and we have 31% that were considered productive, which again means that they recruited at least one person. There were no statistically significant differences in terms of the demographics. So there's not really too much to highlight here. And moving on to the overall network ties. So this would be social support, drug use, and sex networks just across the board, sort of aggregated together. And there's a couple of things that probably pop out to you is that in general, the networks are very small. And when I show you the social support network diagram, you're going to see it's even smaller, starts to winnow down even more. I'm going to try to problematize this in the last few slides that I have. There's really not much here to focus on. There's a few statistically significant or borderline significant findings. But again, when the networks are so small, there's so few ties, it's hard for me to earnestly sit here and say that this means something on a clinical or practical level. But I do think as the study gets larger and we better calibrate some of our tools, that these outcomes will be a little bit more meaningful. The same things here, and now just focus on the social support ties, so disaggregated from the larger networks. We see something that's even more startling. If someone says the average number of social supports about ever using opioids, and they have one tie, this seems a little strange initially, particularly in regards to some of the other research in this space where you're looking at 5, 6, 7, 8, 9 people that people are endorsing as being a part of their networks. And again, we have a few borderline statistically significant results, which again, given the small number of ties, this is a little hard to try to extrapolate on. To wrap up, another thing that we want to do, and I think we will to do, as we start to more refine the methods and increase our samples, start to look at composition, likelihood by some of these different risk factors. So in this first case here, and again, just noting that none of these findings were statistically significant, looking at injector versus non-injector and the likelihood of having someone in your network who's an injector, this idea of homophily, obviously this didn't pan out here with the odds ratio of 1.9, but again, not statistically significant. And similarly, looking at potentially overlap between some of these networks, I think this is a really interesting area. We're not finding too much here either when we're looking at injection versus non-injection, and then having someone in your network that you didn't use a condom with. And same with this last one here. So just to wrap up here, so the big question that emerges out of this is just how are their networks so small? So there's two potential interpretations for this. I think one, and this is very sociological in nature, with this idea that they have small networks because of things like high social closure and just general isolation. So maybe in these smaller communities, they're a little more isolated, they have difficulties finding friends. It's because there's maybe a smaller pool of individuals to pull from. I'm not as convinced by this, but again, this is just one interpretation out of this. More broadly, what I think is maybe a little bit more compelling is this idea that people in this population are trying to escape community judgment and stigma. And a lot of times in our qualitative interviews, we hear people say, this is a very small town and everybody knows everybody. So people trying to sort of avoid those encounters and the judgment that comes with it is not that surprising. So quickly, I'm just going to show you this really nice quote that we had from this 43-year-old who participated in an interview with this white male who says, I don't go and hang out. I might go to meetings now and again or something like that. But you won't ever see me call up a buddy, hey, I'm going to come over and hang out for an hour. I just don't do that. I'd rather be in my own home with my girl. In this case, he's talking about his partner. And he says, I don't have to worry about drama, which I felt like was a really interesting anchor point here of just not wanting any trauma or drama emerging out of these different levels of social interaction. So I'm going to wrap up here. So the second scenario, it just could be hypothesized, and this is the more likely explanation, that people just weren't forthcoming about the size of the networks. And anecdotally, we had people say to us like, hey, like I'm just not comfortable telling you who I shot heroin with last week. And this is, you know, just again, totally understandable, or who I had sex with and how I had sex with them and how many times. Like we totally get that. On the implicit side, people sort of, you know, went with the flow of it, but it's very clear that they're giving us fake names in a lot of cases. So it's like, how do we navigate with this? And again, this is not unfounded. This has been observed in other research, but obviously it's an issue when you're trying to get a sense of the true network size. And all this really is being associated to the social desirability bias and some of the pressures that they may face in trying to meet these different norms that we've established. So just to wrap up here, the face value conclusion that I had, and I feel like I had to bracket it this way, is that in light of some of the social and geographic factors in these areas, the networks of rural people who use drugs, again, opioids, drug injection, they just may be very small and condensed, and this may be irrespective, at least initially from what we're seeing, with their demographic traits or some of these health-related factors that we're looking at. But in terms of social support, if we do care about what this looks at face value and we take this wholesale, then this is a problem in terms of lowering the likelihood of help seeking and also sort of portends poor treatment engagement in general. So in our approach, the upside of this is that while RDS was not very successful, we implemented this VBS approach, I believe back in September, and we had a huge uptick in people who were enrolling in the study. So we know that it's possible. This is a very hidden population, a very mistrustful, understanding population, but we know that it's possible to recruit them and to do it efficiently. But on the other side, obviously, that cuts both ways in the sense that if you're not getting truthful reports when it comes to the data, and really our concerns about the data quality are more on the social network analysis and the other batteries that we had in it, but nevertheless, this is an issue. So obviously, we have some of the limitations in terms of the size of the sample. We focus on one small region in one state. We are hoping, though, with the other cluster sites that I mentioned, that we can have a more comprehensive picture across the United States. The sample wasn't randomized. And also, again, we couldn't systematically validate the network information from the alters. So in closing, as we looked at next steps, and we really had to do some soul searching to figure out, looking at other sites, why, you know, do they have ties that are 6, 7, 8, 9, 10 people, and we have 1, 2, and 3? What do we do about this? One thing that we started in these initial phases is saying that we have to modify our name collection protocol, which is basically just a process of saying, you don't have to give us the full name of this person, but just tell us their first name and the initial of their last name, or maybe even a pseudonym will work instead of giving us a full name. And then again, I think we just need to spend more time in these communities, and probably that involves better training at the PI level, at the investigator level, and also the field staff level. And also I think there's a really important point to be made about the importance of integrating cultural competence and sensitivity into the development of the instrument. So not just how we're working with the staff, but in terms of the questions that we're querying with these populations, are we doing it in a way that are mindful of the sensitivities that they have, the trauma that they've experienced, et cetera. That's it.
Another indication of how hard a lot of this work really is.
Yeah.
Are you planning on re-interviewing the
So like, would there be another wave of it? There's a potential, like usually we'll collect information from the contact information. There'll be a little checkbox, like, are you interested in being contacted? So ideally we would love to, but a lot of that is really just contingent on the funding that we have. But I think it would be wonderful to do that. Yeah.
Is there any way to reverse the analysis? So if you were to take it at face value and say people who are engaged in these activities are less engaged, that you could somehow map the social networks that are strong and then look for where gaps are?
Yeah, I think that's totally possible. I think that's something we've not approached yet because we've just been trying to grappling with what's this dynamic that our field staff have for the people that were, sort of engaging in the field as participants. I think that's totally possible. And I think in the next few months, that's probably an approach that we would adopt just to see, like, are there different ways of modeling what we're doing to arrive at something that actually may be more salient than what we're doing right now. But I think that's a great idea.
Sex is hard because there isn't a relationship, but for drugs without fentanyl was increasingly coming actually from China, from some of the NPR reports, and I don't know
Sure.
if they're by your field, but I was wondering if they could be more individualized.
It totally could be. It totally could be. And I think some of the surveillance that we're attempting to do is really going to complement that line of argumentation and substantiate it one way or the other. Yeah, that's a great point.
Thank you so much.